idiopathic means like we don't know what happened. If you are recently diagnosed with MCAS or you suspect you might have it, you probably have spent hours on Google and come out more confused than when you started. And maybe your allergist ran some tests and they said that everything looked normal and then just kind of sent you home. And maybe you've been on Reddit or 12 different Facebook groups and everyone just has different advice. Hi, I'm Dr. Joyce Knieff. I'm a naturopathic doctor, and I see a lot of complex chronic stuff like mast cell activation syndrome in my clinic. And I'm going to talk about something a little bit different today. This is more of a clear clinical framework for what MCAS is, why you're reacting to everything, and what order you should address things in. Because a lot of the order really matters more than most people realize, and nobody really talks about that part. So before I can tell you what mast cell activation syndrome is, I need to tell you what mast cells do and what they do when they're working right. So mast cells live in pretty much every tissue in your body, and they're concentrated in surface areas like the gut, skin, lungs, and they also do exist in the nervous system and other systems as well. So you can really think of them as these like sentry cells. Their job is to sit at the borders of your body, which are the places where the outside world meets the inside, and they just watch for threats. When they detect something that they interpret as a threat, they release what we call chemical mediators. And histamine is one of those mediators. And it's the one that most people have heard of, but also there are over 200 other different types of mediators. There's tryptase, prostaglandins, leukotrienes, cytokines, there's so many different cytokines, and other things like that. Each one does something slightly different. So some can cause swelling and itching, and the stuff that you associate with an allergic reaction. Others can recruit more immune cells, and others can affect things like blood vessels, gut motility, nervous system activity. So when mast cells work correctly, they protect you, and they're a part of your normal immune system surveillance. In mast cell activation syndrome, that release is happening when it shouldn't. And the things that are not actual threats to you are still triggering that mast cell response. And when that happens chronically, then you end up with symptoms across multiple organ systems because all of these mast cells are just everywhere. So there are actually 3 different types of mast cell activation syndrome. And which one you have kind of can change the way that you approach treatment or what is most effective treatment for you. And I want to lay out all 3 of these before we go any further. So the first type is primary MCAS. This is where there's an actual genetic abnormality in the mast cells themselves. These cells have a mutation that make them just inherently trigger happy. The most well-known version of this is systemic mastocytosis, where there's a specific KIT gene mutation and the body makes too many abnormal mast cells. This is the rarest type and the one that most allergists are actually trained to look for. The second type is secondary MCAS. This is when your mast cells are behaving abnormally because something else is driving them, but the mast cells themselves are pretty normal. The most common manifestation of secondary MCAS are things like IgE overactivation, where there is some sort of positive allergy testing with the IgE, but when the IgE docks onto the mast cell inappropriately responds in a much greater way than is appropriate for just an IgE allergy. This is one that's a little bit confusing because this can cross over with type 1 hypersensitivity. With idiopathic mast cell activation syndrome, this is things where the mast cells themselves are normal, but things like chronic infections, autoimmune disease, tick-borne disease, mold exposures, things like that, where these can make the entire immune system a little bit more on edge. The mast cells themselves are structurally normal, but they're reacting to a persistent upstream trigger. Once you address the underlying driver, a lot of the times the mast cell activity can settle down. This is idiopathic MCAS, and idiopathic just means that we don't really know the cause. The mast cells are activating and the symptoms are real, but we can't really identify a specific genetic mutation or like a clear secondary immune system driver like an IgE antibody. So The idiopathic MCAS is the type that I see the most common in my clinic, and it's the one that is hardest for conventional medicine to work with because there's nothing really super specific to target other than the fact that the mast cells are being trigger happy. Idiopathic means like we don't know what happened. And here's the thing is like idiopathic also doesn't really necessarily mean acquired. It doesn't mean that you did something to cause this. It just means that we don't really have like an established and like a 100% sure pathway for what is driving this mast cell activation syndrome. Most patients that I work with have idiopathic MCAS because they have like no history of previous issues with their mast cells and their allergic type of symptoms. This is something that very often happens to them midlife all of a sudden and is really wrecking their life for it. The good news is that even though our approaches to the different types of MCAS can be slightly different and the medications that work for them can be different, there are different ways to effectively approach each one if you know which one you're dealing with. Because we've talked about the different types of MCAS, let's talk a little bit about the diagnostic criteria. And this is where it can get a little bit tricky because there's two different sets of diagnostic criteria that's in the literature, and depending on which one your doctor uses or knows about, you might get pretty different answers about whether or not you have MCAS. Consensus 1 criteria was developed primarily by hematologists and allergists, and they require 3 different things. First, symptoms consistent with mast cell mediator release across at least 2 different organ systems. So this means that not only do you have hives, you also have like asthma stuff or gastrointestinal stuff or nervous system symptoms. And the second criteria is that you have documented elevation in serum tryptase during or shortly after a reaction. You have a baseline tryptase that is normal, and then when you have a reaction, that tryptase rises to at least 20% above baseline, plus 2 nanograms per milliliter. Third criteria here is a positive response to mast cell-directed treatment, meaning things like H1 blockers and H2 blockers, mast cell stabilizers like cromolyn, ketotifen, things like that. And all 3 of these criteria have to be met for a consensus 1 diagnosis. Consensus 1 is really more about research. Consensus 2 requires a major criteria and meeting one of several minor criteria. So it still requires symptom consistent with mast cell mediator release across at least 2 different organ systems. And then there's 6 minor criteria. A lot of them have to do with genetic mutations, or if you look at a biopsy of the tissue, are there a lot of mast cells concentrated in one area? And this can be like extracutaneous biopsies as well. So if you ever had a endoscopy or a colonoscopy and the doctor has taken a biopsy, you can ask pathology to look at it specifically for mast cells, and that can meet one of the minor criteria. The other ones tend to be things like bone marrow biopsy, looking specifically at the receptors on the mast cells. But there's also options for a wider breadth of testing, including the tryptase, but also including things like histamine if you can catch it, other urinary metabolites like urinary N-methylhistamine, prostaglandin D2, leukotriene E4. These things are all included as like a minor criteria if they are elevated. And then there's response to mast cell mediator therapy. So the same criteria as the third criteria of consensus 1 criteria, but you only have to meet this one and the major criteria. So this makes it so that effectively to meet a consensus 2 diagnosis, you would only have to meet like the 2, 1, and 3 criteria of consensus 1. And this is kind of mostly why it matters, because most allergists will use consensus 1 criteria, and the tryptase requirement in consensus 1 is really hard to meet because tryptase only elevates in a subset of MCAS patients, and it has to be drawn during or shortly after a reaction, and that timing is pretty narrow. A lot of people with really clear MCAS symptoms will never meet this threshold or never have the ability to be able to draw blood at the right time because they're too busy trying to, like their care team is too busy trying to save their life because of the intensity of their reactions. And this is why you can have MCAS with completely normal allergy testing. That's not unusual, and it's actually pretty common for mast cell activation syndrome. There's pros and cons to the two different consensus criteria. I know consensus one is definitely focused in a more narrow scope because they want to be able to do a little bit more robust research on a narrower population. But if we're talking about like patient management, the humanities of like medical care, then consensus 2 serves a lot more patients in that it validates their experience and it gets them access to the medication, insurance coverage, and disability that are things that they need. If you think about when that sink fills up with water as being when the symptoms start manifesting, everyone is going to have like water dripping down the sink. What matters is whether or not you're actually making sure that that water is coming out the drain. And that drain is your body's capacity to handle that load. So the gut is the first system. Your gut is one of your organs that is constantly sampling the outside environment. This is where a lot of histamine metabolism happens and where most of the mast cells in your body actually live. When the gut is inflamed or sort of leaky or has a lot of bacterial overgrowth, the mast cells are getting constant signals to activate. The liver is the second system. So your liver processes hormones, breaks down histamine, handles detoxification of chemicals and toxins, and it produces bile. There is literally a pathway where like adrenaline and cortisol can tell mast cells to degranulate, and your fight or flight system can also suppress parasympathetic activity, so that's the rest and digest stuff that your gut needs to function. So the nervous system is kind of like active in every stage of this entire process. If the wall of your intestines is leaky or inflamed, or the transit time is really slow, these metabolites can recirculate back into your bloodstream because your intestines are just so good at reabsorbing things. This is called enterohepatic recirculation. Naturally, after you work on the liver, then hormones come third because you need the gut and the liver working before you can actually change what hormones are doing what without triggering more reactions. So let's actually talk about how I actually structure treatment. When I first start to work with someone, phase 1, typically, for about 2 or 3 weeks here is like pretty much just stabilize and calm. This is where pharmacological management can really matter and be really helpful for a lot of people. So H1 blockers like cetirizine or fexofenadine, or H2 blockers like famotidine can be helpful, and mast cell stabilizers in severe cases like cromolyn sodium or ketotifen, these can be helpful to just like decrease the reactions people have. In more severe cases, people may be put on like biologics like Xolair, especially if they have a secondary mast cell activation syndrome picture in which their IgE is really high. I have seen people who have normal IgE still benefit from Xolair, so this is worth a discussion with your allergist. All right, if this video has helped you see MCAS a little differently, or for the first time, I put together a free resource that sort of walks through this in more of a written form. This is a PDF that I wrote up. It covers sort of what to start first, what to avoid early on, and why this order matters. And it's kind of written from like more of my perspective as someone who's seen a lot of people move through mast cell activation syndrome and like the different things that they've tried before they came to see me. You can download it for free. The link is in the description. And if you have any questions after you read it, you can either respond to like the email in which you've received it through, or leave a comment here. We do read all the comments, and we use it to like inform sort of what more information is helpful to put out there. I'm also building a structured 12-week program for mast cell activation syndrome patients where we go through every phase of this framework in more depth. And if it's something that you'd want to know about when it opens, you can download the PDF, read it, see if the information in there is helpful. And I can also keep you updated as to when I start doing a little bit more in-depth planning of like that live course that I'm building out here. So yeah, and also if you join the waitlist of the live course and you definitely have something that you want to see in the course, definitely send us a message, because we're still taking ideas right now as to how to build out this course. And a lot of this course is going to be teaching you how to think about mast cell activation syndrome and how to communicate with your doctor so that you best build a roadmap that's specific to yourself. So it's not a set protocol, it is more of like a strategy type of thing. So hope this helps.